Good afternoon, and welcome to Cancer Support Community's Utilization Management Roundtable on Prior Authorization and Formulary Access. I'm Claire Saxton. I'm Executive Vice President for Insights and Impact at Cancer Support Community, also known as CSC. We are a proud leader in patient advocacy and ensuring that voices of patients, caregivers, and survivors play a central role in policymaking and implementation. Today's roundtable is part of CSC's Forum on Utilization Management, now in its 7th year, which was created to foster thoughtful discussions that engage a broad range of healthcare stakeholders and keep the focus on patients and the cancer community that we serve. It was also created to ask tough and nuanced questions about when various utilization management approaches are acceptable and when they have the potential to harm patient health outcomes, as well as it was created to identify new ideas and promising practices that optimize evidence-based healthcare. We are proud to facilitate these discussions and appreciate stakeholders like you for participating and collaborating with us in this challenging but important work. No matter where your knowledge of utilization management lies, we are grateful for your participation today for what we expect to be a very educational and insightful conversation on recent prior authorization and formulary changes related to 2 treatments that affect cancer patients. So Libtayo, which is used to treat metastatic non-small cell lung cancer, and Revlimid, which is used to treat multiple myeloma. A 2005 Humana Medicare Advantage policy announced a coverage change for metastatic non-small cell lung cancer therapy. And beginning in 2025, Medicare and Medicare Advantage are no longer covering Revlimid, the brand, original brand for the treatment of multiple myeloma on formularies, and are forcing patients to switch to the generic lenalidomide. However, this generic version is experiencing a drug shortage, and so patients are having problems with access because of that. Lastly, I would like to reiterate our appreciation to Johnson & Johnson and Takeda for making today's roundtable possible and our work in the utilization management space possible. With that, I am excited to listen into this conversation today with you all. I'll now turn it over to Danielle Ciccone, who will moderate today's conversation.
Thank you for introducing our event today, Claire. As Claire said, I'm Danielle Ciccone, Vice President of Policy and Advocacy at CSC, and I'll be moderating today's discussion. Thank you for joining us for our webinar on prior authorization and formulary access. Utilization management strategies are common policies which, when implemented appropriately in the healthcare system, can enhance the patient's experience and improve quality of care. However, they can also negatively impact patient access to care and contribute to provider burden. As Claire mentioned, CSC is committed to fostering conversations that inform and engage all stakeholders in the creation and implementation of utilization management strategies that include the patient perspective and incentivize cost efficiency through improved patient care and outcomes. We are all here today because we believe that we have a role to play in making high-quality healthcare accessible. To provide some background on today's topic, prior authorization is the process that requires healthcare providers to secure approval from insurance providers before moving forward with care delivery. Step therapy is a prior authorization practice where a payer denies or delays coverage of a physician-prescribed medication until the patient tries one or more alternative treatments. It often ignores an individual's unique circumstance and medical history, which may lead to potentially life-threatening disease progression. It may also require patients to take medications that previously did not work for them or that may cause serious side effects. Lastly, formularies are used by insurance companies to list which medications are covered and may be prescribed as it relates to a patient's healthcare coverage. So, to offer some additional insights into the specific medications that will be mentioned today, we have learned that certain Medicare Advantage plans, like Humana, have implemented a step therapy protocol with the requirement to use the preferred product to treat frontline metastatic non-small cell lung cancer. And for Revlimid, which is used to treat multiple myeloma, we've learned that patients with multiple myeloma are experiencing formulary changes impacting their ability to access this medication. So to give you some context, Cancer Support Community, we've been working closely with both the International Myeloma Foundation and the LUNGevity Foundation on these issues, and will continue to advocate for solutions to increase access to Libtayo and Revlimid. Today, we are joined by Brandon Leonard, Senior Director of Government Affairs for LUNGevity Foundation, who will be discussing prior authorization changes related to Libtayo. Danielle Doheny, Director of Public Policy and Advocacy at International Myeloma Foundation, will provide us with insight into what is currently happening with Revlimid. And last but not least, we have multiple myeloma patient and coach Sally Torgeson, who will describe her experience related to recent formulary changes impacting Revlimid. Thank you again to our speakers for joining us today. And so before we begin, just a few event reminders. A friendly reminder for our live audience that before we begin our official program, that if you'd like to submit any questions, you may do so by entering those questions into the chat box during the program, or you can wait until the Q&A section at the end to ask your question. You will also be in listen-only mode. I just want to make that clear as well. So we're extremely excited to begin this discussion and look forward to what we believe will be a robust and educational and informative conversation. So with that, let's get started. To kick off our program today, we have invited multiple myeloma patient and coach Sally Torgeson to start the conversation by discussing the impact of recent Revlimid formulary exclusions on patients. Sally was diagnosed with multiple myeloma in 2018 and later became a myeloma coach to give back. She travels internationally as well as throughout the U.S. as an active member of her community, family, and as a myeloma coach. Sally, thank you so much for being here with us today, and I'll turn it over to you.
Thank you very much. My name is Sally Torgeson, and I am a myeloma patient. I've been asked here today to share my story, my experience of living with multiple myeloma and navigating its complexities, and the unexpected challenges I have faced with my medication and Medicare. It's a story I believe that carries essential lessons for all of us. My journey began in 2018. It wasn't a typical diagnosis. I ended up in the ER after pushing out of a chair and separating my sternum from my collarbone. Despite my pain and knowing something was wrong, the ER X-ray technician said there was nothing wrong. I had to advocate for myself, insisting on a CT scan. Eventually, a CT scan revealed the truth. My collarbone looked like, as my doctor said, like a mouse had nibbled across it. I had multiple myeloma. Looking back just a few years to what feels like the dark ages, standard treatment was RVD, Revlimid, Velcade, and dexamethasone. At that time, with my standard Medicare and Anthem Blue Cross, there was no question, no pre-authorization hassles, and I responded well, underwent a stem cell transplant and achieved MRD negativity without Medicare telling me what I could and couldn't do. All was covered without exception. However, myeloma can be a relapsing disease. In 2022, it came back. We explored newer treatments like venetoclax, but it didn't show the hoped for progress. I was presented with treatment options, and I opted to go back on Revlimid, a drug my body had tolerated well in the past. Then came the unexpected. In February 2025, Medicare informed me that they would no longer cover Revlimid, and I was switched to the generic lenalidomide, not by my doctor, but by Medicare, an insurance company. Excuse me. Within 24 hours of taking lenalidomide, I experienced a terrible itching and nausea. My body reacted very differently to the generic. My specialist thankfully recognized the issue and stopped my Revlimid cycle. His team worked hard to get me back on Revlimid, providing that even so-called bioequivalent drugs can have very different side effects. Although lenalidomide is bioequivalent, it is not the same. It has different fillers or non-reactive ingredients, and I'd already lost one cycle of treatment that was going to stop the myeloma from growing. This experience taught me some invaluable lessons. Listen to your body. Contact your doctor immediately if you experience unusual side effects after switching medications, generic or not. Please don't dismiss it. Don't wait. Document everything. Keep detailed records of your symptoms, medications, and all communications with your healthcare team and insurance company. This is what saved me because I had every hour documented of what happened to me on lenalidomide. This record is your best defense with the insurance companies. Seek support. Organizations like Cancer Support Community, the International Myeloma Foundation, Health Tree, and Patients Rising are all there for a reason. They provide education, resources, and advocacy. They can help you navigate these challenges. My experiences also highlighted the control that the insurance companies can have over our healthcare, especially today, with the current administration trying to cut expenses by removing drugs like Revlimid from the 2025 formulary. Access to medication can change quickly with little or no warning. This is why patient advocacy groups are so critical. They fight for our access to the treatments we need. I became involved with Patients Rising, a patient advocacy group, Cancer Support Community, and I support the work of Hilda's Club in Middle Tennessee because we need to raise our voices. We as patients and you as caregivers must be your own most potent advocates. We must work with our healthcare teams to make the best decisions for our bodies, not allowing those decisions to be driven solely by cost-cutting measures. We can make a real difference by sharing our experiences and advocating for ourselves, for our caregivers, and for others. And I thank you for listening, and now go out there and roar.
Excuse me. Thank you for saying that the last point, go out there and roar. I think that's very telling because we are a community of passionate advocates. And I just want to thank you for being so honest and sharing your experience. And, you know, I am heartened to hear that you were able to get back to Revlimid, in that you had a sophisticated care team and your physician knew to get you back. About how long did that process take you, right? Like from when
I
they,
jumped on it literally 4 days after I started lenalidomide, and before the end of the month, I was able to get Revlimid back.
great. And how are you doing now? How's your quality of life? It seems talking to you, you're pretty active, and like you said, you're retired, but your dance card's fuller than when you were working. So
That's true.
yeah, so just thank you so much for sharing your perspective. Thank you for being a coach, and just being that voice and like really helping other people understand who are impacted by multiple myeloma, how they can advocate for themselves and ensure they get access to life-saving and life enhancing care. That's why we're here. You are why we do what we do at Cancer Support Community and the other groups you mentioned, like Patients Rising and Health Tree. So with that, what I would like to do to continue this conversation is to next bring in Danielle Doheny. Danielle Doheny is Director of Public Policy and Advocacy at International Myeloma Foundation. In her role with the International Myeloma Foundation, she advocates on behalf of the multiple myeloma community to the executive and legislative branches of the federal government. Danielle is here to discuss updates with Revlimid and what we can do to support patients. Danielle, thank you so much for being with us. I'll turn it over to you.
Thank you so much, Janine. I'm Danielle Doheny, Director of Public Policy at the International Myeloma Foundation, or IMF. Just as a small background for folks who may not know, myeloma is a type of blood cancer. It starts in the bone marrow, and my dad's actually a patient as well. He's had it since 2012. And I think something really important to mention that for many, many years, this disease had very few treatment options. There was almost nothing for patients, and the lifespan, their life expectancy was very short. But Revlimid, the drug that we're talking about today for myeloma, it was approved by the FDA in 2005. And it's really changed the treatment landscape for myeloma. There's been a lot of innovation since then, and many, many of our patients are able to live pretty long lives. But prior to 2005, there just really wasn't much out there. And this drug has just been, I know whenever my father was diagnosed, we were told, don't look up the life expectancy because it wasn't factoring in these new drugs. Of course, the first thing we did was look it up, and it said it was about 2 years, and he's still with us today. He was diagnosed in 2012. So they really, really have made a big difference. But we have a lot of access issues related to any medication out there. This particular one, prior to this, there was always Medicare access issues that were out there that required folks to really seek out financial assistance. And that's why we all came together and we were advocating for that $2,000 out of cap for Medicare. We were really, really excited for this to take effect. We thought personally, we were one of the poster children for people that would benefit from this. There was an article that came out that had a chart, and Revlimid was one of the top drugs that would benefit from the cap. But starting pretty soon after open enrollment began this year, we started to get some really questionable emails coming in and phone calls. And I'll just read the first one here. And it came from Paul, who is one of our support group. He leads our info line, and it said, "Hi team, I just got off a call with a Houston area caregiver who is looking for a Part D plan. She has found no formularies offering Revlimid, but they all offer lenalidomide. They've also experienced lenalidomide's unavailability, and they are not feeling secure about this. Have any of you experienced similar issues now that it's open enrollment? I'm now informing you, advocacy and support groups, and I'll CC you all here, but just know that I just wanted to know what your team was hearing." That was our canary in the coal mine moment. It came in on October 8th. First thing I had ever heard of this being an issue, and then they began exploding. The next one came in a few days later, and it was from someone in Minnesota, and they said they're a leader of a support group, and they just had their yearly pharmacy and Medicare update meeting. They're all shocked to hear from their insurance broker that all major PBMs are excluding Revlimid from their formulary. Generic lenalidomide and Panelists are both on the formulary. Even applying for formulary exception, our broker informed us that Revlimid would be excluded from the $2,000 out-of-pocket cap and would be subject to 25% copays. Needless to say, this is a big issue for our patients. To add to the insanity, generic lenalidomide is not fully rolled out at our local specialty pharmacy, and we cannot get it yet. Our pharmacist has heard that pharmacies do get it, reach their maximum shipping volume mid-year, and they often have to switch patients back to Revlimid. In addition, a couple of our members have been on generic lenalidomide and could not tolerate it and had to switch back. So once we started receiving more than one of those, we reached out to our colleagues and many other groups. We reached out to Deneen at Cancer Support Community. We reached out to Triage Cancer. We reached out to all the other myeloma groups just to see, are you guys hearing this too? And then also once we realized it's a trend, we all came together, had many calls on Zoom. What do we do about this? And what can be done for patients? We had no idea. It was all information trickling in bit by bit. We had to kind of put a massive puzzle together, figure out exactly what is happening, and can we fix this for patients, and how do we fix it for patients? And the solution that we came to was to inform physicians to request brand only, to be able for folks to be able to take advantage of all these reforms that were positive. And I think there's a lot of issue that comes from that, where it does increase often provider burden. And then you hear from folks like Sally who experience delays to their care. I think one massive thing that I guess something important to mention, we're not hearing from folks they cannot get their drugs. Once people know about the fix, they are getting them, but it's delays. And with myeloma, that can be very problematic. As Sally mentioned, bone lesions are something that happen to patients when their disease isn't under control. We really just don't want to see people when there's a drug out there that can help them, not able to get it.
Absolutely. Thank you so much for all of your advocacy and us working together as a patient advocacy community. Danielle's right. When she reached out to me, I immediately reached out to our financial navigators and our helpline, and they were like, "Yes, we're hearing this too." There's this formulary exclusion. There's this real concern about access and delays, and what can we do as patient advocacy groups to really support our community. There's one piece I was wondering if you could maybe talk about a little bit for those that maybe are not familiar with the 2000 cap that you mentioned and that reform that the Inflation Reduction Act ushered in. Could you talk to them a little bit about what that cap is, so they can understand,
Yeah.
what the Medicare prescription payment plan is, the cap and smooth and all that?
Yeah, absolutely. So this is something we advocated for many years. And finally it crossed the finish line because we were hearing from a lot of people that their Part D expenses were so burdensome. And finally, as part of the Inflation Reduction Act, they did include a provision that allowed patients to pay $2,000 total for their Part D drugs over the course of the year. And there is also an ability that patients can have to smooth those costs over the course of the year. And another thing that our communities all brought to Congress, we would tell them 2000 is still a really big bill to hit people in January. Is there a way that you can come up with a way for people to kind of have smaller payments? And they came up with that MPP and the MP3 program so that people could spread those costs over the course of the year. So it really has the potential to help a lot of people.
And 2025 is the first year, right?
Mhm.
Yeah, yeah. And there was one other question I wanted to ask you, kind of when we're talking about medication access for people impacted by multiple myeloma. Could you talk a little bit about any other changes or any other medications that are in the multiple myeloma space that we're seeing in the Medicare program, where there's been some changes, particularly the Medicare drug price negotiation program? Um,
Sure.
and in the drugs that, some drugs that maybe have been selected for the next round of negotiation, and what might you be monitoring in that space as well? That might be
Yeah.
helpful just to kind of on the horizon
Mhm.
for people to be on the lookout for.
Yeah, absolutely. Another myeloma drug, one was selected as part of the on the negotiation list. Pomalyst is a drug that I can say my dad was on it, and it was whenever he had been on many different treatments for myeloma, and many of them had failed them. So it's not people who have like early stage disease that are taking this. It's people who have been through the ringer and been on a lot of different combos of medications and drugs. But our concern with that one is it's definitely with formulary design in the future and step therapy prior authorization. And we think that this same issue could actually happen in the future for Pomalyst as well, because that drug is set to go generic shortly after the negotiated price would take effect. So we're really just watching what's going to happen with formularies in the future for that one. And it's it's definitely a burden for patients. We don't want to see that happen there either.
Yeah. Thank you. Thank you for that. I just wanted, for those that maybe aren't as steep day to day in the policy and advocacy, just wanted to make them aware of that as well. So thank you. But before we turn it over to Brandon, I just wanted to ask you, do you have one final thought or takeaway or tip for a patient or caregiver as it relates to like understanding, navigating our insurance system and what they can do and how IMF is a resource?
Absolutely. I think when it comes to navigating their insurance system, really take advantage of our groups. We have so many resources, so many specialists that can help you. If you get something, an issue where you're realizing you're having trouble getting a drug, just let us know, because it could be a situation like this where you hear one story and it ends up being a trend, and you have thousands of people going through the same thing. And we did write a letter to CMS stating this issue to them, that Centers for Medicare and Medicaid Services, to make sure that the folks who were in charge of Medicare knew about this problem. And we're also talking to legislators about this problem whenever we're meeting with them, saying like, hey, there's this issue, but if you don't let our groups know, we can't jump in and try to help. And we also, sometimes it'll be situations where we take a policy stance and kind of come together that way, but sometimes it'll just be, we already have a guide, we have some steps to take that can help you navigate this problem. And most of us have people on staff that are experts in this, so just any one of our groups, give us a call and we can help.
Absolutely. And one last point I'd like to make before we transition to Brandon is, we were talking a lot about what we're seeing in the Medicare Advantage space. We are also beginning to hear that this policy change is happening in commercial plans as well. And so the patient advocacy groups that are on the call, the caregiver groups that are on the call, um, if you get wind of this as well, feel free to reach out to cancer support community, reach out to Danielle. As she said, we are a community, we work together, and we collaborate, because we want to have a sense of what's happening and exactly the breadth of it so that we can continue our engagement. Like she said, we have reached out to the Centers for Medicare and Medicaid Services to share our concerns about the formulary access issue with Revlimid. And if and when we begin to learn from commercial payers as well, that's another type of advocacy we would want to do as well. It's really important that we have those lines of communication and we really bring that patient perspective when we talk to payers, private or public. We always share to them why this medication is so vitally important from a patient and caregiver perspective. So I did want to put that one last call to action out there for those who are on the call today. So thank you so much, Danielle, for sharing all of the incredible work that you all are doing at IMF. And so what I'd like to do today is shift a little bit our time remaining to Brandon Leonard. So we're going to hear from Brandon, who is Senior Director of Government Affairs for LUNGevity Foundation. In his role, he leads LUNGevity's legislative policy activities, including outreach to Congress and state legislatures, analyzing bills, and developing policy statements and letters. He also coordinates LUNGevity's Early Lung Cancer Policy Coalition and represents the organization in numerous other coalitions. Brandon co-manages the LUNGevity Action Network, a platform to engage the lung cancer community with educational events, articles, and advocacy opportunities. Today, Brandon will provide insights into recent changes related to Libtayo and possible solutions for improving access. Brandon, I'll turn it over to you.
Great. Thank you so much, Deneen. And I want to thank Cancer Support Community very much for the opportunity to speak with you today and to talk about this important access issue. As Deneen said, I'm the Senior Director of Government Affairs for LUNGevity Foundation. We are a nonprofit organization that is dedicated to supporting the lung cancer community through research, through opportunities to provide community, through support groups, and both online and virtual events, as well as to advocate for the community in terms of policy solutions. So I wanted to start by giving you a little bit of background on lung cancer before I get into kind of the heart of what I want to talk with you about today. So lung cancer is the second most common cancer diagnosed in both men and women, and is the leading cause of cancer mortality in the United States and in the world. There are two main types of lung cancer, small cell and non-small cell lung cancer. And non-small cell lung cancer accounts for about 80% of all lung cancers. In some ways, to mirror what Danielle was talking about, we've seen really extraordinary advancements in lung cancer research and treatment over the last 10 or 15 years. And so the number of options for treatment and the specialization of those treatments has really grown exponentially. And that's providing hope to people who are newly diagnosed with lung cancer, as well as people who have been living with lung cancer and need to find new options for treatment. So I'll be talking specifically about non-small cell lung cancer today. And for patients who are diagnosed with non-small cell lung cancer, immunotherapy is one possible treatment option. And a type of immunotherapy called checkpoint inhibitors helps the immune system fight cancer by targeting proteins on either the immune cell or the tumor cells. So it's basically helping to break down a barrier where either the tumor cell is telling the immune cell, hey, I'm good, don't attack me, or the immune cell is kind of being blocked itself from attacking the cancer cell. So these drugs that target this mechanism are called PD-1 or PD-L1 inhibitors. So PD-1 is for a protein that's on the immune cell, PD-L1 a protein that can be on the tumor cell. And there's another type of drug called a CTLA-4 inhibitor, and this also boosts immune response to cancer by blocking a different kind of protein called CTLA-4. So in some cases, the best treatment option for a patient might be a combination of PD-1 or PD-L1 inhibitors along with a CTLA-4 inhibitor. So these are just some of the many options that are available to patients based on their particular profile. So all of these advances have really been working toward the personalization of lung cancer treatment. And the therapies that I mentioned may also be combined with other types of treatment, such as chemotherapy. So with that background, I'll talk a little bit more about the particular issue that I was asked to speak about today, which is regarding Humana and their coverage under their Medicare Advantage for particular types of treatment. So Humana is the second largest Medicare Advantage provider behind only United Healthcare. So the decisions that a payer like Humana makes have a huge footprint on our healthcare system. Back in November, Humana announced an update to its coverage strategy for PD-1 and PD-L1 non-small cell lung cancer for Medicare beneficiaries to take effect at the beginning of this year. This update applies what's referred to as a STEP strategy in Part B for frontline non-small cell lung cancer treatment, and it's using a specific preferred drug, Libtayo. Now, for some patients, Libtayo may be the drug that is prescribed by their provider. In that case, this is not an issue. For other patients, their provider might recommend one of the other drugs that's approved for treatment of this particular type of non-small cell lung cancer. Or they may recommend a combination of treatments, PD-L1, PD-1, PD-L1, and CTLA-4 inhibitors. And in that case, this presents an issue. So there are several concerns that we have with this new policy. At the basic level, it's undermining the ability of a provider to choose a treatment that they feel is most appropriate for their patient, given that patient's individual circumstances. The strategy that is being employed by Humana also does not align with clinical guidelines from the National Comprehensive Cancer Network for treatment of non-small cell lung cancer. NCCN guidelines don't recommend a STEP approach. And for some patients, the guideline recommended treatment option would be a combination therapy. So the Humana strategy doesn't allow for this option for first-line treatment. So in this new step strategy, patients would have to start with coverage for the preferred drug. And then if their provider had recommended a different treatment for them, they would either have to go through a appeals process, which could take weeks and delay access to care for that patient if they were to win that process, or the patient would have to start on the preferred drug. And if there came a point where that treatment was no longer working for them, or if they had side effects that were difficult to manage, then they might go through a process to be able to get on the drug that their provider had recommended for them in the first place, or the combination therapy that their provider had recommended. So at this time, Humana is the only insurer to adopt this policy, but we're also concerned that other payers, including big ones like United Healthcare, may follow their lead. This could end up impacting a very large segment of the population of the lung cancer community. So what does this mean for patients right now? So patients who were already actively on another treatment within this category prior to the change happening shouldn't experience a disruption or a barrier to continuing to get the treatment that they were on. But patients who are newly prescribed this year under one of the non-preferred treatments would be subject to the new step strategy. So they'd have to go through with their provider that process. I also just wanted to talk a little bit about some of the advocacy activities that have taken place regarding this decision. So in December, LUNGevity, along with Cancer Support Community, and Go-To for Lung Cancer, led a community letter to Humana that voiced our concerns about the policy change and urged them to reconsider. The letter was signed by 28 organizations, primarily those in the lung cancer space, and our partners such as CSC, who support everyone living with cancer. We also sent a similar letter to CMS asking them to take action and prevent the policy from going into effect. We didn't receive a response from CMS. We did receive a brief response from Humana, but they didn't indicate that they would reconsider their policy. We do anticipate having a call with them soon where we'll have an opportunity to voice our concerns live and see how they would respond to those concerns. We're also considering other activities, including outreach to Congress and bringing more awareness to this issue through media channels. And so I definitely appreciate the opportunity on this webinar to bring more attention to this important issue. I'll also say that because this policy is so new and applies to patients who would be starting therapy this year, we haven't heard a whole lot of stories from particular patients about this impact yet, but we anticipate that that will be happening as more and more people are diagnosed this year and would be recommended to have a different therapy option. So I'll be happy to put my email in the chat. If anyone personally, or if you know someone who has been impacted by a policy like this in lung cancer, please do reach out to me. I'm happy to coordinate efforts with our partners, including CSC, on how we can effectively respond to this. And I think that having specific patient stories that we can share with policymakers, with media outlets, with Humana itself, can help us to really highlight and explain why this is so, why this is so important and how it may be adversely impacting patients. I'll also drop in the chat the letter that we sent to Humana and to CMS before. So thank you again for the opportunity and look forward to the discussion.
Yeah, thank you. Thank you so much, Brandon. A lot of great work happening there. And thank you for throwing, the letters to CMS and Humana in the chat. I wanted to ask you, you mentioned, we sent that letter to CMS and we haven't heard anything back. With the new administration, and I know we're waiting for the CMS administrator to be confirmed, do you anticipate an opportunity to re-engage this administration related to this issue, or do you? I know I'm asking you to do a little bit of crystal balling, so no one's going to hold you to anything you say. But do you think that there might also be an opportunity to maybe make some recommendations that this administration might be receptive to as it relates to really reducing those barriers and delays to care as it relates to prior authorization and utilization management, using this situation as an example?
Yeah, certainly, I think so. When we sent the letter to CMS last year, we knew it was late in the year and late in the administration. And so we felt like it was important to send that because that administration had expressed really, strong concerns about people being limited in their access to the best possible therapies. And we wanted to take that opportunity. I think with this administration, I think certainly goals that they have stated in terms of access to therapies, it is worth also taking this issue to them and seeing how they would respond to it. And I think it's a good concrete example to take to, whoever would be the most appropriate folks at CMS and just show how these policies can impact access to care. So I do think that's one avenue that we'll be pursuing.
Wonderful. And you talked a little bit about Congress. For those on the webinar who maybe would like to learn more about how they can get involved with their member of Congress, could you just talk a little bit about how that outreach might look and where the potential is, right, for patient and caregiver feedback and input when we talk about how these decisions can have real impacts on a patient's access to care?
Sure. So I think, you know, one of the ways, and I kind of alluded to this before, I think one of the most effective tools that we have for advocacy is stories. And so if whether it's this specific issue, because I know, this is right now, it may not be a huge number of patients who are impacted, it'll grow. But if it's this issue or if it's another issue, then I think having a story that's your own or someone that you care about that you can take to a congressional office, and that can be in any number of ways. So you may reach out to that congressional office by phone. You can email them. There are also a number of organizations like LUNGevity, like CSC and others that have platforms that patients and advocates can use to contact members of Congress about issues that are important to them. So you mentioned the LUNGevity Action Network up top. This is a platform that people can use to write their members. We have campaigns there about specific topics. So right now, those are focused on things like research funding and changes at agencies that are happening right now. We'll add throughout the year other campaigns that people may want to use to write their members of Congress. You can also use those for talking points if you want to contact your members separately and talk about that. And then the last thing I'll mention for that, if you have the opportunity to meet with your member or their staff in person, that can be a really effective touch point. Not everyone can come to Washington, D.C. I mean, that's one way that you can do it, but also your members will have time back in their districts during recess. And that's a really good time to go and talk to often the member themselves, but if not, then you can meet with a staff member and voice your concerns. And that's a really effective time to get your message across about this or any other issue that you're concerned about.
Great point. I want to echo what Brandon said. When they're back home in district during recess, that's a great time. And the feedback we hear often from members is those are the encounters with their constituents back home that really resonate with them. Um, you know, yes, of course, the members are open of always to meeting on Capitol Hill, but they seem to be most impacted, or there seems to be a deeper impact, I guess you could say, when they talk to their constituents back home in the community. So I want to put a +1 for that recommendation. that Brandon made. And one last question, and I'm going to open it up. So everyone, please start, if you haven't already, please start putting your questions in the chat or start having your questions for all the panelists. But last question, and Brandon, and this is because, you know, for those who don't do policy and advocacy day in, day out, just really quickly, if you could just explain and share how, if needing to employ a congressional approach to the issue that we're seeing here, how does that play into like what's happening at CMS? Just so they can kind of have an understanding of how policy works, right? Overarchingly, they may not necessarily make the connection to, oh, I can also reach out to my member of Congress and tell them this. What might be the call to action or the outcome for someone doing that as it relates to CMS?
Sure, no, that's a great question. So, you know, when we reach out to CMS, we're asking them to take a particular regulatory action or to make a change in coverage policy, and apply it either within, you know, Medicare, Medicaid, or the private market. Congress has the authority also to tell CMS what, you know, what kind of policies they should consider or take action on. And so I think CMS may feel like a little bit of a harder nut to crack, I think, for a typical advocate, and I think for all of us in many cases, in terms of how quickly the agency could move on something or where the right touch points are. Going to Congress, meanwhile, you know, they are directly responsible to their constituents. And so I think that can be an avenue to put pressure on the agency to take a particular action. And I think, you know, if you have a specific patient experience that you can point to illustrate why this is an issue, then that may compel a member of Congress to raise this to the level of either legislative action or perhaps you know, doing their own fact finding and outreach to an agency or to an insurer. So I think both of those strategies can be effective and they complement each other.
Yes, well said. Thank you so much. Okay, so we're going to bring in all of our speakers, our phenomenal speakers, a great discussion today. So again, I'd like to say in the time we have remaining, we will now open up the discussion to questions. If you have a question for one or all of our speakers, you can submit them in the chat box feature now, or to ask your question. So I am going to see, I'm going to take a peek in the chat box and see if we have any questions for any of our panelists. Do we have any? It looks like, Sally, you were pretty active in the chat, so that's great. It looks like there was a lot of great conversations and engagement happening there. So that's fantastic. Let's see, there's a comment here. Okay, so someone made a comment I'd like to just share with the group. There appear to be two key issues impacting cancer drug access through payers, like United Healthcare and Humana. First, formulary changes are increasingly directing large groups of patients toward alternative therapies, which may seem reasonable from a public health cost perspective. However, when these alternatives, often generics or non-brand therapies, are not effective or well tolerated, the need to switch treatment places undue burden on patients, providers, and could lead to improved. I think the comments are coming in fast. Okay. And this, I'm sorry, I think I lost it. This is ultimately a customer experience issue. Okay, great. To address this, so here's the recommendation. Policy reforms could focus on reducing payer monopolization through anti-monopoly legal action and requirements that employers offer a choice of at least 3 healthcare plans during open enrollment. Increasing competition among payers could also lead to improved service and better patient outcomes. Thank you for that very thoughtful approach, that very thoughtful feedback. Does anyone have any reactions to anything? It kind of seems like it kind of reiterates or some of the key themes and messages that we talked about throughout our discussion today. But I'll just open it up to the group. Is there anything that anyone on the panel wants to say in relation to that very thoughtful comment? Okay, I think you probably summed up pretty well what was the focus of this conversation. Are there any other comments or questions in the chat? I'm not seeing any, so I get the feeling that we had some great speakers today, and you all did a phenomenal job explaining the issue and really making the case for why, patient and caregiver perspectives are so important, and why we need to be involved in decisions like this, and really bringing the community together so that everyone can be aware of what's happening, and we can share best practices, and we can share what we're doing in the advocacy community. And so what we'll do now, the time we have remaining, I think we can close out today's discussion. And so what I would like to do is say, on behalf of the cancer support community, I want to thank again all of our panelists, Sally Torgeson, Brandon Leonard, and Danielle Doheny, for your invaluable insights on this issue, and to all of you who attended today's event. Looking forward, we are excited to announce our discussion around utilization management at our upcoming Utilization Management Summit that will take place in person on Tuesday, June 10th at the City Club of Washington in Washington, D.C. Please be on the lookout for an invitation to that event to save the date, and we really hope to see you all there. We hope you found today's program valuable, useful, and informative, and we encourage you to get involved with CSC on this issue as it continues to evolve. You can also reach out to LUNGevity Foundation and the International Myeloma Foundation as well. So with that, that concludes our program today, and thank you all so much for attending. We appreciate you.